Hello everyone. In today's class, we are going to discuss the complications of Chancroid, the clinical variants, HIV and Chancroid, and the differentials of Chancroid. Let's start. In the last class, we had discussed the clinical features, which is mainly the ulcer and the bubo. So the complications will be the complications of the ulcers and the complications of the bubo. The ulcers, especially in males, may form phimosis, paraphimosis, phasogenic ulcers and urethral fistula, while the bubo may complicate by ulcerating, forming sinus, fistula and might even scar. Now moving on to the clinical variants of Chancroid, which is a very important part of Chancroid. The first one is the giant Chancroid. It is a single large granulomatous ulcer which extends peripherally. It is more than 2 cm in size and it occurs mainly at the site of a ruptured bubo. Now the dwarf Chancroids. They are mainly remain in the pustular stage or may develop into small, very superficial ulcers. It is very similar to herpes genitalis. The next one is the follicular Chancroid. Here the ulcers are in the follicular distribution and they are mainly seen in women because of the hairy area of pubis and labia majora. It looks like folliculitis. Moving on to the fourth type, it is transient ulcer and it is very superficial and very transient. It heals and the bubo remains. So it is also confused with LGV. It is also known as chancre mou volant. It is in French. Mou means soft and volant means gliding. So it comes and it goes. It's very transient. The next one is papular. Here there is a granulomatous papule which ulcerates and it resembles donovanosis or condyloma of syphilis. It is also known as ulcus mole elevatum. Next one is the serpiginous. Here there are multiple ulcers arranged such that when they coalesce they form a very wavy pattern. It is known as ulcus mole serpigiosum. Next in the queue are the phagogenic ulcers. These are large destructive ulcers. They are mainly superinfected by fusospirochetes. These are a mixed colony of fusiform bacteria and spirochetes, and they are mainly known for the causing Vincent's angina or trench mouth. They are also known as ulcus mole gangrenosum. Now the eighth one is the pseudogranuloma inguinale. Here the ulcer morphologically looks like the donovanosis, the granuloma inguinale. But when you culture the organism, it comes out to be Haemophilus degree. The differential will be donovanosis. This is the last one, the mixed Chancroid. The ulcer here is hard and indurated single ulcer. It is by coinfection of H. degree and T. pallidum. This was all about the variants. Next we'll move on to the topic HIV and Chancroid. Now in HIV and Chancroid there are two aspects. First is the effect of HIV on Chancroid. So when there is immunosuppression of HIV, the Chancroid presents very late. So there is delayed presentation of Chancroid, and that is the incubation period will be increased. Now if once the clinical signs and symptoms comes, it will be severe. So there will be much more in number, multiple, and it will be necrotic, it will be destructive. Now the third is when you give the treatment of Chancroid, the response is poor. So there will be treatment failure and there will be delayed response. You might have to repeat the drugs for treatment of Chancroid. Now the effect of Chancroid on HIV. So when there is a Chancroid, there is already an ulcer, there is damage of the barrier. So there will be easy acquiring of the HIV infection. Due to the bleeding ulcers, the blood exposure is more. So let's write down damaged barrier and blood exposure. The second point is that once you have got the HIV infection, the seroconversion of HIV infection is very fast if you have a concomitant Chancroid. So if you are given to write on this topic, HIV and Chancroid, please include all the investigation, the diagnosis, the management and the treatment part as well of both the diseases, HIV and Chancroid. So moving on to the last topic for today's discussion are the differentials of Chancroid. So all the genital ulcer disease, there are 5. So all the other 4 will be the differentials. The first one is very easy, it is chancre. Because of the name it is chancroid. Chancre is solitary, it is hard, painless and it doesn't bleed. The next one is herpes genitalis. What are the difference in chancroid and herpes? There is vesicles in herpes, there is no vesicles in chancroid at any stage. There is pain but it is less than chancroid. There will be a prodrome and there will be systemic signs and symptoms which are absent in chancroid due to absence of bacteremia. The third one is donovanosis. Donovanosis is painless, it is indurated, it has a beefy appearance, the margins is very distinct, it is elevated or hypertrophic in donovanosis. The last one is the lymphogranuloma venereum. It is very easy because the ulcer here is transient, so you can only see a bubo. The difference in bubo of a chancroid and LGV is that in LGV it is bilateral, it is multiple and it is multilocular, while in chancroid it was usually unilateral and usually single and unilocular. There will be constitutional symptoms and the very famous groove sign is present in LGV. Now once you have given all the differentials of GUD, there are other differentials like it can be candidal balanitis, it can even be like FD or Behçet's disease, and at last you should always rule out traumatic ulcers. With this we come to the end of today's class. In the next class we will be discussing the diagnosis and the treatment of chancroid. Thank you. Bye.